Good morning. I'm going to talk a little bit about affordable housing, which actually Kevin's been the only one to even make mention of affordable housing today. So we're a very small sector, but I'm a housing practitioner and have been for the last 35 or so years. And although I have a new position with Mercy Housing, I think I'll speak much more from a California perspective where I've been working for most of my career. And what I'm going to talk about today is maybe better aligning service-enriched affordable housing with healthcare partners and payers. And then talk a little bit about a case study that we have engaged in with the Department of Public Health in San Francisco. We're a mission-driven organization founded by the Sisters of Mercy of Omaha. And currently sponsored by nine other congregations of Catholic sisters. This is important from the perspective that housing is like the third ministry of Catholic women religious, and they are the sponsors of many large national Catholic healthcare systems. We work in 41 states. We own and operate about 17,000 units of affordable housing. And when I say affordable housing in this context, we're basically talking about housing that is restricted by funders, either public funders or tax credit investors, to a very low income population. We house very low income families and frail seniors, very low income seniors, and people with special needs. Primarily, these are formerly chronically homeless individuals who are living in a service-enriched environment. So we've had some long-standing and pretty robust partnerships with large Catholic healthcare systems. They started partnering with us in 1998. They have invested financially in our organization. Kevin mentioned some of the housing production help they have given us. Very low-cost pre-development loans are incredibly important to our ability to incubate and produce affordable housing. Sometimes they've had surplus land or facilities that they have provided to produce affordable housing. And on a community-by-community basis, we're involved in a lot of programmatic partnerships, and those could be funding for our programs and services in our buildings, health educations and screenings and follow-up care for people, immunizations, fitness classes, free car seats, charity care for people who are living in our buildings, village nurses, school supply for kids. It goes on, and it really is a community-by-community kind of relationship that provides these kinds of programs and services. And none of these are particularly payer relationships with us. So we are working a little bit more on accelerating our work with healthcare more from a payer system. The Affordable Care Act has provided us with some opportunities here, and we're about 2.5 years into this journey about thinking about affordable housing as healthcare and affordable housers as viable healthcare partners. And it's been an incredibly frustrating journey in some ways because, one, the healthcare world is very chaotic. We've heard a lot about, just kind of differences in data and approaches and assessments. And in California particularly, the duals demonstration has been slow to kick off. It has been delayed several times. And there is this huge kind of chaotic environment around us. I tend to think that out of that chaos will come innovation, because having the glass half full is a whole lot better than having it half empty. But I think that the healthcare world, both from a healthcare system, a managed care perspective, an accountable care perspective, and a federal policy perspective, is really not quite ready to embrace affordable housing as a true partner yet. But I think we're really quite on the brink of something happening here. So we've started to look at the kind of work that we do in housing somewhat differently. For years, we have been working with very well-defined program models as it relates to community wellness in our properties. We are dealing, as Gary said, with socially complex populations, people who are very fragile, very vulnerable, and have a lot of needs. And we have been working with people, in partnership with people, quite in our own little silo, in conjunction with other community-based services and supports, but not in true partnership with healthcare. So in thinking about what the opportunity is for affordable housing, we are thinking about our program models much more in terms of coordinating the care of people and partnering with their healthcare providers to ensure that they have good access to care and good compliance to care plans and to the other supports they need in order to comply with good, healthy living. We were working on service models that would reimburse us for some of those services, and then the holy grail of everything would be to partner with healthcare to really produce more units of affordable housing. When we think about affordable housing as a social determinant of health, if people can live in a place that they can afford, that is clean and safe, that has a safety net of caring staff around them, that is close to public transportation, that isn't infested with any vermin, and that gives them the opportunity to have an engaged and caring community around them, then that really is healthcare. And that is a place we're trying to get to in a much more sophisticated kind of way. So we have approached service provision in this kind of way for quite a long time. And it was quite surprising to us when we sat down with a healthcare system to talk about this kind of health and wellness model of programming, that it was all very nice to them, but really not very compelling as it related to a partnership. So we've been working at reframing this a little bit, because some of the services that are provided in an affordable housing setting are really quite high value. And if we can help people maintain their health coverage and navigate their care and do various health screenings, and if we can do chronic disease self-management programming and other evidence-based programming, and provide stable, decent, affordable housing, this is really a very good community outcome. And so we get to our triple bottom line here. So I want to talk a little bit about Mission Creek and how this got put into action starting about 7 years ago in San Francisco. We have the wonderful advantage of working in a very progressive city who is a good paying partner, and with the Department of Public Health, who has really been among the leaders in the nation of Housing First programming. Mission Creek is in a new neighborhood in San Francisco called Mission Bay. It's by the ballpark, for those of you who know San Francisco. 10 years ago, there really was nothing there. It was a bunch of old rail yards. But now, quite a vibrant community. There's 2 light rail lines that run right in front of this building. It's adjacent to a multi-use recreational path that runs along a creek. There's a brand new public library on the ground floor of this building. There's an adult day healthcare center on the premises. There's protected inner courtyards for outside activities for people. There are large, sunny, numerous community spaces. There are lovely apartments with good light, ventilation, and views, and a strong partnership with the Department of Public Health. I would say that this particular building, which there was a picture of in one of these presentations, is virtually indistinguishable from numerous very high-scale, upscale apartment buildings that surround it. There's also a supermarket on the corner. So this is 140 units serving all very low-income, frail seniors. And 50 of them are people who are referred to this building through the Department of Public Health. Some of them have been moved from the county long-term care facility, Laguna Honda. Some of them came from shelters, some of them came from living in their cars. And they all come through a direct referral from the Department of Public Health and have a very good set of wraparound services through the Department of Public Health. And the Department of Public Health pays us $700 per month to house them in what is a very vibrant and service-enriched building. We provide our usual range of services in this particular property, but a physician that we work with at the Department of Public Health, Dr. Bamberger, would say that this environment really is magic. Because what happens here, aside from the service provision, is that there is 24-hour desk presence. There is a licensed case manager. There are language-specific activity coordinators. And so there is community here. There is caring and engaged community here. And there is access to a physician at all times. And so a few years in, this physician, Dr. Bamberger, he published a paper that said something like this. Because these are people that were followed by the Department of Public Health over time, that there is about $30,000 in annual savings for each of the participants, each of those 50 participants, and that there are reduced hospitalizations and skilled nursing stays. Now, the problem with this is that the data is not exactly robust enough, and we need, I think, to understand more if we are to align the health benefits of affordable housing with the interests of healthcare payers and providers. We need to know a little bit more about what data they have and what data they want from us, because I think that there's some opportunity to further our work together. In California and across the country, Medicaid will pay for skilled nursing or residential care facilities that cost immensely more than what Mission Creek costs. And Medicare will pay for hospital beds for people who have been treated in an acute care setting for whom there's no place for them to go upon discharge. And so this model is constrained in many, many ways. We would love to do hundreds more of these. But there are not the public funds producing housing right now in the same way that there might have been in the past. Medicaid does not currently pay for supportive housing as an alternative to skilled nursing. And we're housing a very, very low income population. We're housing people who are paying $200 to $300 per month for a setting that costs probably about $2,000 a month to do it and do it very well. We think we have an opportunity to demonstrate that we can reduce hospitalizations. I guess maybe all hospitals might not be interested in hearing that, and so when we talk about aligning our interests, how this gets framed might be important. We're talking about reducing institutional care, and this one is of high interest right now in California, particularly to the Department of Long-Term Care, in thinking about perhaps, according to the director of that department, 11,000 people on any given day in the state of California who are living in a skilled nursing facility, mostly because they don't have any other place to go to, at huge cost. So hopefully the shifts in the healthcare world right now will provide further opportunities for funding affordable housing. If in fact the healthcare sector is moving in the policy sector for pay for service to pay for value, and if we're shifting our focus from sick care to healthcare, and if patients are being migrated to managed care plans, I think this does create huge opportunities, not only for us as affordable housers and for other community-based services, but for very low-income people who really will achieve much higher health outcomes if they are living in a community environment that is safe and affordable and supportive. So our key drivers, no surprise here, How will we get paid to do more of this? You know, I'm quite sensitive. Somebody said, it might have been Gary. This is not about wanting to kind of poach Medicaid dollars or healthcare dollars. This is about really feeling passionately about the fact that very vulnerable people can live very successfully with better health outcomes in a community setting, and that we're all about that. And it just takes a little bit of resources to, in fact, perpetuate an affordable housing environment. And we're working with, you know, we've got some good, robust partnerships with healthcare partners, and we need to figure out how we work in better alignment with them. That's a constant process that we're engaged in right now and will continue to be engaged in. Thanks.